I will just, before you do, I'm just going to hand over to our next speaker. So I'm just going to introduce them. Our next speaker is actually Professor Jerome Saris, who I will just put on. Oh, not working. There we go. There's all the references. There he is. And the reason I get to introduce Jerome is not only am I MC today, but he is actually my PhD supervisor. So I've got to be nice. He's still leading me on my way. He's been a lot of experience, Professor Saris, when it comes to mental health. And I'll let you look up his details on Hoover. Very, very impressive academic career. And thank you, Jerome, for joining us today. I'll hand over to you.
Thanks, Justin. Can you hear me? Excellent, excellent. Well, I will have to say, saying that he should be nice to me, and then I think he's eaten 10 minutes into my talking time, so we'll have to get him back for that. But a fantastic talk, and it really is wonderful to be following up Justin. So just, yeah, one of the absolute leaders of the field. So is that's come up? All good? Can't hear anybody, so I assume it's all okay. Look, welcome from, I should say, a partially sunny Melbourne. I am a bit jealous I'm not up there on the Sunshine Coast, although I did speak to our director just before and said it's raining or about to rain up there. So I feel a little less, jealous about the situation. But look, have a great conference. Yeah, fantastic work. And thank you to Lucy for the invitation to speak and her amazing work. So today, yes, I will be covering medicinal cannabis for mental health applications. The relevant disclosures, always important ethically to outline. I do conduct medicinal cannabis research as part of NICM, received also consultancy payments in the area and do work for ANTG as well. But I do, play a very straight bat when it comes to the data. So, pardon me, so as Justin articulated, and what's good about Justin speaking before me is that there's some areas which are covered beautifully, so I don't really need to go over them. But in regards to, and he's touched on this, the prevalence of use, you can see there, aside from chronic pain, that anxiety, insomnia, PTSD, sleep disorders, ADHD, even depression, really are the common, or amongst the most common conditions which people are using medicinal cannabis for. And well, the other thing is, I think, as you would be aware, is that there is very high comorbidity between these particular disorders and symptom presentations. So you will see people who will present with a corollary of these symptoms, and something which does have broad effects, such as medicinal cannabis, I think really is quite ideal because of the interface between these comorbid conditions. Justin's covered this nicely in terms of the dosage form use, but in regards to mental health specific usage, I think the data is fairly consistent and with general use, and certainly, as was indicated, that vaporization is growing. So I think years ago, when it first came out, it was mainly oil products available, and the vaporization of smoking was perhaps preferentially seen more in the recreational market, but as good quality flower is coming through and there's a bit more clinician education, we're finding there's more use, and certainly that makes sense in terms of the alacrity response being much quicker, which is of course important for example, pain disorders. Looking at the CAMS 18, I saw the CAMS 16 was covered before from Nick and Ian and the team, our friends and colleagues down at the Lambert. Captures it really beautifully that people are using medicinal cannabis for these conditions. As I mentioned, the pain, anxiety, sleep being amongst the top. But when you look at the data in terms of survey-based data, what effects they're getting, you can see there, blue and the red, very much improved or much improved in terms of their symptom relief. Now, of course, it is a bit of a captive sample that people generally would be filling out these forms who do have an interest in the use of cannabis, but really still quite encouraging data. And you can see this sort of reflected in terms of pain, mental health, sleep being the main condition, or amongst the main conditions being used. So it's covered before, and that's the problem when Justin gets there before me. He just, bleaches the land. You can't get in there with any pharmacological data because he covers it all. But just to reiterate, yes, obviously CBD and THC are most studied constituents and do have different neuropharmacological modulations in regards to their activity. Probably something of note, I guess, to this, or more mental health focused, is to explain, look, it's a multi-target drug or agent, if you like, which does work indirectly with, or working with the serotonergic, dopaminergic, also the endocannabinoid system, which also, those particular systems, as we know, do have a role with mood, with anxiety, with also sleep and pain. Interestingly, there's animal data in regards to PTSD models showing that it also can have an extinguishing effect on trauma, and that could be via the endocannabinoid system modulation. But there's also a range of other effects which are covered in terms of immune system modulation, as well as HPA and neuroplastic effects as well. Covered once again the various cannabinoids and terpenes. What I will say as a mental health focused comment is that really we've only just explored, I think, the tip of the iceberg. Yes, we've got a lot of data on THC and evolving data on CBD, but the minor cannabinoids there's really not much on, and the terpenes, whilst preclinical based evidence in terms of in vitro or animal models, I think is really what makes it quite special. And to do with the chemovars or the chemotypes which people may prescribe, which will, I think, get increasingly more evidence-based, and we'll get more data, hopefully more patient-derived data, as to which of these particular formulations, can be used for certain conditions. And I think certainly these terpenes do play a role in the mental health application as well. Obviously, as Justin was covering, some of them do have anti-inflammatory effects, antispasmodic effects, also soporific, and anxiolytic activity as well. Some of them also have mood elevating effects as well. So we conducted a review, myself and Justin and other colleagues. It's a few years old, but I've actually gone back, well, a couple of years old, gone back and looked to see what other data is out there. And really there isn't much since we conducted this. So, pardon me, this is actually an open access article. Happy to send it to you, or you can just look this up, and it's quite a comprehensive, clinically focused review. Now, in terms of the overall evidence, social anxiety was one of the first conditions studied. This was using CBD acutely, and it was at fairly high doses, 400, 600 milligrams as a dose, which is higher than what the TGA is recommending for our current studies to look at, which is 150 milligrams, which is what the S3 bar is currently set at for pharmacy-only medicine. We obviously have to get the data in, and then people can apply for that and sell through pharmacies. So a bit higher dose, but there was a reduction of social anxiety and social phobia, which I think is quite interesting, quite encouraging. Needs to be obviously a repeated RCT design if people are looking using that more chronically to see the effect. Generalized anxiety disorder, there is a study underway. It tends to be focused on youth, and I think it's our colleagues at Origin in Melbourne are conducting that. A couple of studies, I think, involving CBD for that. Depression, no primary outcome studies. However, there has been data showing that very high THC load for some people may actually reduce people's mood. Potentially that could be because if people are really having quite a sedative, strong effect from the THC, it may be reducing, for example, physical activity. There may be also comorbid pain they're addressing as well. There may be other psychosocial elements going on. So it may not be directly from the THC. What we can say is that THC acutely, for some people they're reporting, the data certainly suggests it can be mood elevating for people as well. And I'll talk to that data quite soon. OCD, there's some animal data to do with, from memory, marble burying. So they do these little OCD animal models, and the rats I think they sort of wreck the sand and furtively bury things, and everything's a bit chaotic if they've got an OCD phenotype. Otherwise, things are a bit more smoother, and I think there's less marble bearing when they're being treated appropriately, which CBD has shown to have that effect as well. There's some case studies as well, and a very small RCT. So we can't really comment that this is a valid treatment at the moment. PTSD, really solid observational data, and certainly it is used quite commonly in vet clinics over in states in America, which do have it as legalized. There's some really strong, encouraging epidemiological or survey-based case study data. However, there was an RCT by Dr. Sicily, and unfortunately negative, but then she'll always point out the quality of the cannabis which she received from NIH was shocking, and really it is the quality of the medicine which will correlate to the effect. So I think we can't really, unfortunately, we have to take that with a grain of salt. ADHD, one small RCT, mixed evidence. Some domains with the ADHD study did show some improvement on ADHD domains, on others not so much. We need, of course, as usual, more robust research on this. Schizophrenia, 3 clinical studies to date. Some have been positive, some have been equivocal, and I think one was showed no results. But they're looking at using for this is the CBD, not THC, which is contraindicated in schizophrenia. 600 milligrams to a gram of CBD, so a fairly high amount of CBD. So how, can that be also effective at lower doses, which, let's be frank, are more affordable, especially if a patient's got schizophrenia. Obviously, there sometimes can be challenges with employment and income, so that's something which will have to be explored. Insomnia, only case studies in a small RCT to date that I'm aware of. However, as I'll talk in a second, there's thankfully quite a few going on currently in Australia, which is fantastic. So I did a bit of a search on the Australian-New Zealand clinical trial registry network, and it's really exciting because of the TGA's position about allowing CBD to be an S3, that it's encouraging research in the area, which is fantastic. Personally, I'd also like to see more research on whole plant preparations and ones which include THC. But nevertheless, it's just great to see research on cannabinoids. So here's some examples. We've got an insomnia study. I think this is being conducted at Swinburne. That's underway. It's looking at I'm not sure what the dose is there for the CBD, but so looking at 2-week supplementation, so a short study. There's also one looking at brain changes and also depression in early stage dementia. So that'll be an interesting one. And that's looking at 300 milligram dosage. So that'll be quite exciting to see the results of that. And I think also, it's important also with agitation, with dementia, sleep issues as well, potentially pain management in that cohort as well. It is also something which could benefit potentially from cannabinoid therapies. Very interesting one here. I think this is conducted over in Western Australia by Steve Bright, a colleague and a friend over there, looking at impeding methamphetamine relapse, which I think is obviously a critical area of treatment which we need. So that'll be interesting to see whether CBD can have a role with that. The Origin group also doing some more work looking at risk psychosis youth and seeing whether CBD may be able to prevent transition into full psychosis. So that's an exciting study. And then also another CBD study here, which is, I think that one is being conducted. Oh yes, that's the one with Dr. Janet Schloss. I think it's the PROMISE study, so that'll be fantastic to see. It's got a very large participant group, 438, so that's going to be really fantastic, and a heck of a recruitment job as well. So we'll see how that goes. In terms of some of the concerns around cannabis, and we do have this raised regularly, if we're talking to medicos and then through the media about the link potentially of psychosis. What we can say is that, look, yes, there is a link, and I think the data does show that. However, it's important to know, based on the data, two considerations, well, probably three. One is that we're looking at youth, where the brain is more plastic. So if you're getting earlier use, interfacing with a pre-genetic disposition for schizophrenia, so that could be, you can see that through familial history or potentially through traits, and obviously through, the diagnosis is the most important thing. But also what they're taking. And the key thing here is that if they're having a skunk or a very high THC, especially smoked, a form of cannabis which has low or absent CBD, or some of the synthetic cannabinoids, there is an increased risk in terms of, psychosis transition. So we do need to be very careful about that, because there are concerns around that. And that being said, as we said, as we move towards CBD-rich preparations, even with THC in an older cohort, I think that there's obviously there's less issues, and usually by then the tumescence of schizophrenia would have presented at any rate, in the majority anyway. In terms of cannabidiol in cannabis flower, this is a very interesting study, just something for us to ponder. This was a naturalistic study looking at, I think it was in Colorado, people coming into the clinic and they were given a washout, given a THC dominant one with hardly any, this is a flower, smoke preparation, hardly any THC, so 24%, that's quite a strong THC preparation. Balanced flower with CBD, THC, and then one with higher amounts of CBD and low THC. And they could have it ad libitum in terms of sort of using this over a period of, I think, 5 days. What I find interesting about this study is that because users will report, they love, people who use it more, I guess you'd say recreationally, love the subjective high. And you can see there with the black line, that is the THC flower. So it's showing a stronger subjective high. The CBD flower, not so much. That makes sense. I mean, it is psychoactive, but it's not so much an inebriant. But if you look at the THC in combination with the CBD, so the balanced flower, they're reporting a very similar uplifting of mood, also with euphoria as well, and also drug liking. So they're actually enjoying it. And let's face it, most people will do things in this realm because they are also enjoying it. I don't have an issue with that personally, as long as there's the safety issues minimized. But if you look at the paranoia and the tension down the bottom, you can see that was only far more predominant for the THC alone. So the point I'm getting at is that if you're prescribing a combination, as long as you've got enough THC, if you're wanting to elicit pain reduction, for example, maybe for sleep as well, and management of certain mental health disorders, you might as well also have something which does have CBD in it, because they're still going to get the effect they want, but you're minimizing the paranoia and tension. Another study here, which involved 91 healthy participants, and this looked at acute and residual mood and cognitive effects, because people just say, well, hang on, this stuff can knock you around, affect your cognition, and so forth. And interestingly, after 1 hour of smoking, this is sort of acute use, pretty obvious high THC group. There was a bit of confusion, but there was also increased friendliness, elation, and interestingly, a decrease in fatigue. And I think for some people, they do find it quite elevating and stimulating. Depends, I think, on the cultivar, and we do need more work done on that. But what we can say is that after 24 hours, for some people, yes, they did have a carry-on effect in terms of mood, but in terms of cognition and cognitive impairment, no issues the next day. And I'm sure people are talking about driving, and I'll touch on that later on at the end of the talk. In terms of the relationship with anxiety disorders, there is an association, it's just a brief article to reference here, between individual studies looking at correlation between anxiety and also cannabis use. Yes, there's a positive association, but what we can't tease apart with something like this, a cross-sectional study, is whether that's because they have anxiety and they're using the cannabis to treat their anxiety disorder. So I don't think there's anything too worrying in that respect. Lara Sharp and our group at NICM conducted a review of this area, and really the take-home message, I think, builds upon what I was saying before, was that the CBD tends to have the data supporting an anxiety-reducing effect. The THC has been shown to, for some people, increase acutely anxiety, paranoia, may elicit panic attacks. Once again, this is, on an individual basis, far less likely to happen if given with CBD. And also the sort of start low, go slow with the THC means that you're less likely to get those anxiogenic responses. That being said, a final comment on this. Interestingly, some people, when they looked at it in terms of anxiety disorders, what they preferred using, and it was the higher THC cultivars. So not entirely clear cut. Our final study here, just before a couple of concluding clinical comments. Very interesting study, newish study looking at medical cannabis card ownership. So they received a card which allowed them to access, in this particular state, it was in Colorado, to access cannabis. One group was given the card and they could access the cannabis straight away. The other group had to wait, I think, 12 weeks before obtaining it. And they had pain, insomnia, and a range of conditions. Now, you can see there on the left there, when they got given the card acquisition, their cannabis on the y-axis use was increased, sort of average 3 to 4 days a week. That makes sense. The delayed one, held off, although towards the end maybe that some of them started having some. And then in terms of the relationship of cannabis use disorder, it was higher in the using group. But then when we look at the elements of cannabis use disorder, it's people using cannabis, right? And they're, getting an effect from it and they're wanting to use it. So it's pretty reductive looking at that. And just at the conclusion, which I found quite interesting, was that in regards to pain severity, depression, anxiety, compared to the delayed cannabis users, there was a slight improving, although not statistically significant, for a couple of those. But insomnia was the one which, really stood out in terms of people getting very strong benefits. And it makes sense why so many companies are doing research in that area. But also, interestingly, there was reported improving of certain cognitive domains as well. So, it makes sense, certainly if people are managing their symptoms well, that their cognition is going to improve. And also you can see there on a range of exploratory outcomes, on, for example, pain, perception of pain as well, severity of their condition, and so forth was improving, as well as up the top there, mental well-being was described in the cannabis using group as being far more superior. So finishing up here, I think Justin captured it really quite well. I think it depends on the condition of the participant. Usually people aren't going to load up on THC during the day unless it's usually a pain-related condition, or say for nausea, chemotherapy-based work. Some other conditions, maybe multiple sclerosis and so forth. Mental health conditions, there is a preference, I would think, for sort of CBD focused medication through the day, and then the THC may be used more preferentially in the night. Also, of course, as Justin talked about, working out clinically whether it's an oral product or a vaporized or inhaled product as well is important. Obviously, avoiding or minimizing in younger populations THC is obviously important. And the thing is about the green market, so to speak. Some doctors have said, "Oh, why don't you just get it from the black market?" I mean, at the end of the day, you just don't know what you're getting. And I think the market here is sophisticated enough that we do have a lot of quality control. And unfortunately, it is expensive, and that for some people that can be prohibitive. But regarding the quality, that is absolutely the way to go. Issues, which has to be looked at clinically in terms of current medications. There needs to be clinical thought about that, certainly in terms of narrow, drug window, therapeutic index. Respiratory diseases, more so for the inhaled forms, and also, looking at potential sort of past drug or alcohol use disorders. But that being said, some people do medicate with CBD and potentially some THC, to I guess in a way reduce their use of alcohol and other substances as well, and also just some getting the advice and clinical sign off in terms of conception and so forth. Final comment, as I said before. Start low, go slow, and that's something which a clinician can work with the patient in regards to getting to the sweet spot for what works. So yeah, look, I've covered off on the major data to talk to. The only thing I'd say is that driving, that's something which we're trying to address through regulatory mechanisms, because I mean it is ridiculous. We're certainly not expecting people to have high inhaled THC and go out and start driving. But if you get a situation where you get a salivary test the next day, and then if something comes up and they're completely not impaired, and the data does say support that they are not impaired, really we need to make sure things are adjusted, that it's less punitive and discriminatory upon people using this as a medicine. And the next research steps, as a final thought, I'd just love to see more based on these whole plant preparations to really draw on the potential therapeutic benefits of some of these other cannabinoids and terpenes. So that's my contribution today. I hope you have a great conference, and all the best up on the Sunshine Coast. Thank you.
Thanks very much, Jerome, and you kept that to time. I think that's a first for you. Well done.
I went over, and I didn't think that was a first.
No, and I think
kept to time. That is a first. Yeah.
No, it's my fault for sending you over. So thank you very much for that, Jerome. I know it's some big attendance here. I wish you could see it, but thank you for the insight when it comes to the psychiatric side of things, because it is important. It's, as I've said before, it's not all milk and honey. There are challenges that need to be considered clinically, and they're important to take into account. So thank you very much for your time today, Jerome. Really appreciate it. And everyone, it's afternoon tea time. I'm sorry that we were the people that made you late for that. So go get some coffee, and we'll look forward to seeing you in the next session. Thank you very much.